Welcome to the ResearchWorks podcast, broadcasting live from the Oceania Academy of Cerebral Palsy and Other Childhood Onset Disabilities Conference 2026 in the beautiful city of Hobart, Australia. Join Dr. Dana Poole and the ResearchWorks team as we bring you an exclusive series of interviews with visionary keynote speakers and leading presenters, captured right here amid the groundbreaking discussions and innovations shaping the future of disability research and care.
Hello everyone, welcome back. So glad you could join us for another episode. We are here at Oceania 2026 in Hobart, Tasmania, Australia. Marissa, how's your brain going?
It's good. Yeah. Still need that bit of paper to write my notes down to get things out of my brain, but it's been amazing.
How inspiring has it been?
It's
been
so inspiring.
Wonderful. And every time we speak to someone, we add another element to things we need to consider and how we can implement it into our practice. And our next guest is no exception to that, because there's so many clinical implications for this. When I read the title of this article and looked at the abstract, I thought, wow, so many of our listeners are going to love this. So welcome to the microphone and to the pod, Anne McNee.
Thanks for having me.
Thank
nice
you.
to be here.
So nice to have you.
Thank you so much for being here. Look, you have come all this way. It's a long way from the UK. It's a long flight, isn't it? But you've come all the way to Hobart. We're so grateful for that, because you presented on an article that's titled Evaluating the Effectiveness of Serial Casting for Idiopathic Toe Walking in Children with Autism Spectrum Disorder. We don't see many publications on this. We don't see much work being done on this. Yet clinically, it's something we think about a lot and have conversations with parents a lot as well. How about you give us a bit of a background about why you decided to go into this area and look at this data?
That's a great question. So it's interesting, isn't it? So if we could probably reduce the title down to serial casting in autistic toe walking, only because there's been a recent publication in regards to idiopathic toe walking is something we all come across.
Yes,
and there's a big spectrum, and I come from the orthopedic perspective. So the kids I see have a contracture of ankle plantar flexors. They've got a fixed ankle plantar flexor contracture. So I think there's probably split into two. There's the toe walkers that don't develop a contracture and those that do. And I'm not sure we know an awful lot about why, the whys and the hows.
Yeah.
And so I suppose the serial casting came in a little bit more. We started doing a lot more. I work in neuroorthopedics at the Chelsea and Westminster Hospital in London. And we're a tertiary centre for northwest London.
Okay.
And so we do see a lot of people of all different neurodisabilities, but we seem to be picking up a lot more children with autism, a lot more idiopathic toe walkers. And in the literature, you'll find that idiopathic toe walking sometimes has, autism. They may or may not have autism, but it seems that they might be very much a distinct group themselves. So also in the literature, I think what you find is that everyone says it's a throwaway line that is actually they don't tolerate it. They need anaesthetic to change a cast. They won't tolerate surgery.
Wow. Yeah.
And that's just not what we found in clinic. And I suppose England was hit a little bit differently from COVID. And surgery closed down. All the in our hospital specifically, all the theatres were used as intensive cares.
Oh, wow.
So we had no surgery.
Right.
So actually we've got an option of providing casting. So our casting tended to take off a little bit more, or not take off, that's probably the wrong word, but we seem to be wanting to do something. We thought we'd have a try of those with a little bit more substantial contracture than we probably would have tried before. And actually the results we thought we found, we were seeing some good results and that they were tolerating it the way we were casting. And so that's why we decided we'd have a look at our results over the last 5 years.
Oh, that's fantastic to be able to publish this result and to be able to talk about this information, because you're absolutely right. There are a lot of these throwaway lines, and I'm not sure where they necessarily come from, but they do make their way through, and we all start repeating it, and we kind of have to wait and go, where did we get that information from? And I've certainly heard that too. If you're thinking about serial casting and a child has autism spectrum disorder, it's like caution, in terms of a management strategy, isn't it?
Absolutely. But in terms of, and what you think if we're not doing this for kids, and I know even as a therapist, I've had this sometimes where I think about trying something with a child and I'll think, I don't think they'll tolerate. But I'm learning more and more that I give it a go. But give it a go knowing what they're like. So having things in place to help their tolerance. And I know you spoke about that when you were applying the cereal cast. You were acknowledging they had ASD and you used techniques to help, I guess, their acceptance as well of the treatment.
Yeah, that's right. I mean, we use as I said yesterday, we use a normal clinic room. It's nothing fancy. We've just got some LED lights that change colour that they can choose. They can use the buttons. We give them the controls. You're in charge of the lights for the room.
Makes it fun for them.
The bright clinic lights are down. We've got a light in the ceiling. If we don't tend to use it a lot, but we do have access to a sensory box, which has got lights and bubbles and things in a tiny clinic room.
Yeah.
But we also give them the option of what do you want to watch on TV?
Yes.
What do you want to, do you want to use your iPad? We get the parents to say, if they settle with food, if it's at a time where they need to be, if they're hungry, bring some food. We're not bothered in the slightest.
Yeah.
Bring your sibling. They can be involved in the process. They're helpful. They've got hands. They can help bring the casting kit in, with us to go and get. So we can adapt it to them. But I think, parents of children who have autistic spectrum disorder know they've got to prepare their child for whatever's coming. So the clinic appointments are longer. We have a discussion with them. We see them probably twice to discuss the process so they fully understand it before we go ahead.
Yes.
And I think the other thing that we've found is very helpful is that we do casting and sitting. So they are in control. They know what's going on. They like to see it. It's not in prone. And we also find we can control the foot a bit better when it's in sitting and it's on a platform. So those things seem to work for us.
And I love that there's no major wild adaptation that you had to do something for. But what you're talking about is knowing the child, giving them some control, altering the environment if you can so that it suits their needs, but also ensuring that you're not rushing into it. And I think that's often where things go wrong, isn't it? Is if you're not spending that adequate time in preparation.
Yeah, and I think that's right. If you think you're going to take a minute, it's always going to take 10.
That's right.
And if you think you're going to take 10 minutes, you relax into it. Actually, you get it through a lot quicker. I am not saying, certainly for, when you're talking about autistic, I mean, I have split it into your different autistic spectrum classifications.
Yes.
I don't know if that's the one, there are lots of different ones around, but we stuck with the level 1 needs less input or support, and 3 needs a lot more. The 3s, children who have more needs probably do take longer.
Yeah,
but we've just built that into our clinic and we adapt the clinic for their needs.
Yeah, just as a bit of an idea, and I know it'll be different for different kids. But if they are level 3 and are you doing bilateral casts? Unilateral?
If they're a toe walker, they will be bilateral casts. Yeah.
And how long would that take? Maybe what does the first cast look like, and what does a second cast look like?
The first cast, so we will have gone through all the equipment. They will have seen all the casting material that they need to see. They will have seen the room before. We will have described the whole process. They will have seen the kiddie gate splint that we tend to use afterwards. So we've hopefully shown them all the things that they will meet.
Yes.
We've shown them the plaster saw. We've turned the plaster saw on. They've felt the vibration from the plaster saw.
Great.
So the first appointment, we will assess them again, and we'll have everything out. Do you remember all these things? And then it really does depend on the child. But actually, if they're settled, we can have them out the door in 45 minutes.
Wow. Okay.
But then, of course, the change of plaster is change of cast.
Yes.
Obviously, those ones do probably take a bit longer. But we tend to have our appointments, and so it's not much longer than that.
I was going to say, it doesn't sound much different to that, does it? I think the fact is you're putting in lots of preparation that goes ahead of time, but it's important to know, because I think people might think it might take so long, they're sitting there for so long, what that could look like, and preparation is key.
No, I think we've only had one chap who is on the autistic spectrum, but he used cerebral palsy, and there was one, he took quite most of the morning, but that was a specific issue that we needed to get to the bottom of. He didn't want to go shopping in a particular shop, so he didn't want to be involved. So actually, it's actually trying to work out, and sometimes without parents there, we can get to the bottom of what the issue is, and often it's not the casting. Often it's something else. But we've got that relationship, which seems, and I think it doesn't take long, as long as you're there asking the parents and the child actually what they need.
So soft skills again, isn't it?
Soft skills.
Yeah. They come in play just as much as your clinical skills, right?
Absolutely.
Always in everything we do. So getting into your results now, so this is a retrospective review during this period of time, and you had 28 children come through that you included in the analysis, aged between 2 and 14. Tell us a little bit about what that looked like for you in terms of...
Oh, okay. So it's a little bit, so actually, because people will start jumping up and down about the 2-year-olds. So I think there was that, we actually excluded that from the results that we've now published. So it's actually between 3 and, I think it's 3 and 14 now. So actually I went back through the data and I've added some, and actually there was one that I was a bit worried about. So actually I've taken them out because we're not sure of diagnosis. So I didn't want to muddy any waters.
Sure. Okay. So in terms of what you found from those kids in terms of their tolerance and what the results are from a, I guess, range of motion perspective, what was that like?
So if we start with the clinical results, as you will, because that's what people are interested in, is that actually the overall group has a plantar flexion contracture of about just over 10 degrees, the whole group.
Okay.
The ASD level 1s and 2s are around about 8 degrees.
Okay.
But your ASD 3 have come to us and they're getting towards a 20-degree contracture. So at the start of casting.
Okay.
So actually, what is interesting, splitting the different groups, is that actually we're getting the really the ones that need more help.
Yes.
That have more trouble with life a lot later.
Right.
And so, but then overall as a group, they gained about 13 degrees of range of motion. So we aim towards plantigrade or just beyond.
Right.
That is not a functional amount of movement, but I think we find if they do stick to their, if there's a post-casting protocol, which I'm sure we'll go through, and they use their ankle and they're using their splints, we do find that if they're getting a heel strike, they do tend to gain more range following the casting. So that's why we don't want to push it any way beyond that. And it seems to work for us. So where that is measured with the knee, both in flexion and extension. Okay. To be honest, I'm more interested in the knee extension because that equates to standing and walking.
That's right. And how many casts on average would there have been?
It was an average of, there was a average of 3 casts, but between 1 and 4, depending on their contracture at the beginning.
Yeah, right. So those are more of the clinical outcomes. What did you find with regards to their tolerance and how they actually took to serial casting?
Yeah, so actually...
Because you measured that via an interview or no?
So we did a questionnaire with 15 of those families. Right. Just to get parental feedback, actually, what do you think? Is it harder than you think? Is it what are you gaining from it? And so, actually, what is the overwhelming feedback was that it was really manageable. That they needed information, and most people said they had enough. But someone really highlighted the fact that actually we need to give them as much information as we can. We need them to have, because we know that that's what they need, and so. I think that just underscores the importance of, sensitive and accessible information for the child and their family so they can go through it, so they're understanding what the process is coming up. So that was one of the feedback from them. And overwhelmingly, they all achieved at least one goal. And the goals, this is not just a range goal. This is about, the goals were along the lines of improving standing balance, improving their walking pattern, obviously, and improving their endurance.
Yes.
And I think standing balance is probably the thing that I would like to focus on most in regards to an outcome, because then they can stand still in the school queue.
Yes.
You do a lot more standing still than you do walking.
That's absolutely right. Or when you have a plantar flexion contracture, that's really going to impact you functionally.
You can't stand still, and so then you're going to get in trouble.
Can you talk to us about that? So you use single limb stance as your measure for balance?
We did. And it's a retrospective study. We're looking at clinical notes, and we tend to look at single limb stance. And obviously, those who are less severely affected were able to stand on one leg, and they actually improved. And actually, we've got some who are now at 2 years down the track, and they're still improving their single limb stance because they've got their range. They're able to do it, so they can practice it.
Yes.
The ASD level 3, often they couldn't stand on one leg, so it wasn't the best measure. But what parental feedback has been is that he now stands and looks me in the eye, and that's really disconcerting because he never stood still before to look me in the eye. So actually, I think we need to probably reflect, we will going forward probably need a different measure, and actually possibly standing with your hips and knees in neutral, standing still, and how long can you stand still for? We hadn't probably, we've hit the floor in regards to the measurement. Or to make it inaccessible to some. So
when they had casts applied as well, did you give them exercises to do at home or any specific recommendations?
Yep. So they get changed. The casts get changed every week. We wedge the bottom of the cast if they're in a plantar flexus position to ensure that they're getting heel strike. And we want them to be able to stand with the hips and knees in neutral, feet in a neutral position, facing forward. And so they go home they have to do standing balance for, it is a bit, how long's a piece of string, but it's at least we try and get it for one song. So that's about 3 minutes.
Yeah, great.
Well, there's just a focus to think about doing it, right? That's the point of it.
So you've got 3 minutes. Yes. Do it for a song.
Great.
And they have, so we're looking at stretching behind the knee because obviously it's a below knee cast. So they do either bilateral or unilateral long leg sitting.
Wonderful.
Prone lying, if that's more comfortable, because then they can be distracted to get the gravity to help.
Gravity.
Nice.
And then walking patterns. So can you walk on your heels? That's when you're getting towards the plantigrade position, or just walking from this tree to the next tree whenever you're walking to school. With your feet in a neutral position. So just giving them kind of physical points that they can, you don't want to do it for long, but just from this point to this point every day you will do that. So lots of standing and walking. Standing and walking is the main thing.
Brilliant. And when the casts are off, what were the main recommendations after that period of time? Was to continue the same kind of...
It is similar, but we have developed a program. We're looking at strengthening and stretching of the ankle plantar flexors and dorsiflexors. So trying to strengthen in that gained range, as well as functional measures, and then working on endurance. We send them off with a selection. There's 3 or 4 parts to it: stretching, kind of strengthening, balance, and then walking activities, and then in different planes.
Yes.
So, looking out to the side as well as going in that sagittal plane. And we refer them to the local physio team.
Fantastic.
We're a tertiary service. We refer to the local community teams. There are different ones around northwest London. And so we hope that they'll progress their exercises or adapt them so they know they're getting on with them.
That's right.
So they're not having to come back into the hospital all the time. We did ask the parents that, and actually only 60% got a physio program.
Okay.
But what they did mention is that they found it really helpful.
Okay.
And I think that's a reflection of how much input they've had potentially in the past.
Sure.
And that they've actually had someone do something and it seems to have worked. So let's move on with that. So I think that's important for us to know that we will continue to do that, and hope that that the local teams can, within their capacities, can help us with that.
And I love that you've said that as well. There's been, within the Australian context, there's been a new sort of addition to how disability services are delivered. And for context for that, we've got the NDIS, but there's also a new stream called Thriving Kids. And in Thriving Kids, there was talk to start off with that there'll be no physiotherapy input for these children with ASD. And so, the groups were very loud in campaigning and going, there actually is a role. And I feel like this work really does highlight it across the 3 different levels that you can get this improvement. Because if you don't, everyone will know, if you can't stand, if you lose range of motion and they get older and they get contracture, well, then that's going to be a burden on the health system if you need to have surgery for something that you could have prevented through quite conservative management and not that many hours.
Not that many hours, no. And it's interesting, isn't it? Because it is improving that, but it's also about footwear and actually about, progressive foot deformity, needing surgery down the track if it's not addressed.
There's some significant things that we can do at a particular point in time, and which is what we're meant to do, right? That's part of our profession. There's prevention as much as it is about intervention, and ideally prevention is the best way to go.
Oh, absolutely. And I think it's interesting you say that, because I think it is prevention, and in idiopathic toe walking and around the serial casting world, that you think, well, it doesn't last for long, so what's the point? And I think I would argue that actually the results we saw, actually, some people are maintaining it up to 2 years. Some are, not all. And but that's reflective of a growing body.
That's right.
So actually your bones grow first and then your muscles catch up. How many typically developing 15-year-olds do you know that have got a popliteal angle of 90?
Yes.
Absolutely right.
So I think if you can maintain a foot structure that is able to hold them, able to hold a normal shoe rather than having such a broad forefoot, then actually maybe you do have to do it again. We always say, even to those who have idiopathic toe walking or the autistic group, we may need to have to do this again. If you grow really quickly, chances are you will tighten up.
Yes, that's right.
And I don't see that as a bad thing. I don't see it as a failure, because it's always said as a failure.
You're absolutely right. The language around that often is that way inclined. But yeah, I think this is really encouraging for us as clinicians and having these conversations with families and with doctors. Main message then from you, Anne, as a final take home for clinicians and people who are listening.
I think serial casting in autistic toe walking is not inaccessible. I think it's very manageable. Parents are happy that you're doing something. I think we've got a lot of work to do on how we're assessing, and what we're assessing. And I think my take-home message for clinicians are: get the children who are walking on their toes, who are developing a plantar flexion contracture, get them seen earlier. Be aware that of the musculoskeletal system as well as all the other needs. I know they've got a lot of other needs, and that may well be a focus, but this may help. And you need casting for less time if you've got less of a contracture.
Yeah, that's right. That's a good final point. Well, thank you so much for sharing this work with us. We are so intrigued by it, aren't we? And it's work that I know that a lot of people will use to advocate for the people that they see as well. So thank you so very much.
Thank you for having me. It's been brilliant.
Oh, good. I'm so glad. Well, enjoy the rest of your time you have here in Australia.
Thank you very much.
And to all of our listeners, hope you really enjoyed that as well. Look, there's so many more interviews to come still, so stay tuned. We'll talk to you all again really soon. Bye.
Bye.